Dr. Sedlander, and we look forward to hearing a little brief glimpse of some of your work, and take it away.
Thank you. I appreciate that. Hi, everyone. Happy to be here with you this morning or this afternoon. I'm going to talk to you today about my work investigating a novel ART adherence strategy or harnessing fertility desires among women with HIV to kind of see how we can increase ART adherence. And this work is funded from an internal KL2 award and also from the CFAR RAP for new investigators to HIV. As Mallory mentioned, my background is really as a social scientist in sexual and reproductive health in sub-Saharan Africa. I've done a lot of work understanding the fear of infertility and how that is a barrier to contraceptive use. And I wanted to understand how that played out in terms for women living with HIV, in terms of how that affects their fear of or beliefs around how HIV might affect fertility or how adherence to ART might affect fertility. And so that's what this work is about. So as all of you know, given advancements in ART, women living with HIV can conceive and give birth safely. However, you might not know that a 2022 WHO meta-analysis shows that 1 in 5 couples experience infertility in sub-Saharan Africa, and women living with HIV face even higher rates of infertility. Several studies, in fact, many studies, thankfully show that ART improves women's ability to get pregnant. But from what I've seen in the literature and from what I've talked to among HIV researchers, nobody is talking about this in terms of how we can leverage this as an ART adherence mechanism. And that's what this work is all about. And the rationale for this is that only 73% of people worldwide are virally suppressed. So we have some work to do. A 2024 scoping review on the impact of infertility and HIV found that the stigma around infertility was much higher than the stigma around HIV. So given the value of motherhood and high rates of stigma around infertility, raising awareness that ART improves a woman's ability to conceive could be a promising mechanism. But to promote ART adherence and to raise awareness around this, we really need a current understanding of what are the perceptions among people living with HIV and the providers who care for them about the relationship between HIV, ART, and a woman's ability to conceive. And that's what we'll be doing through this work. So my work is underpinned by the life course framework, which most of you are familiar with, which goes beyond comparing exposure at one point in time to really thinking about the whole life course. So rather than thinking about fertility or infertility when a couple wants to have a child, this work is trying to think about preventing infertility and promoting protective factors like taking ART throughout a woman's whole reproductive life course. And there are 3 main study objectives to this work. The first, which I'll present very briefly, is our findings from a systematic scoping review of the literature. Next, we'll be conducting in-depth interviews with men and women living with HIV and providers who care for them to understand what are their beliefs, what are their attitudes, what are their understandings of this phenomena now. And we'll be doing that in outside of Nairobi, Kenya. And then next, we'll develop a survey around knowledge about HIV, ART, and fecundity, the ability to conceive. And we'll test if knowledge that ART is a protective factor, is that statistically associated with ART adherence among women in Kiambu County, Kenya, who have some interest in having a child in the future. And of course, our hypothesis is that it is, that knowledge that ART is protective would promote ART adherence in women who want a child. And so all of this, these 3 aims will then inform development of an ART adherence intervention, harnessing these strong fertility desires in women. And so I'll very briefly, very fast, just tell you that we conducted a systematic scoping review from 2000 to 2024. We had a large search, cast a broad net, and we found almost 2,000 papers that fit our search criteria, and ultimately ended up with only 17, which was disappointing in that we put a lot of work into screening and reviewing the full text. But we're optimistic that we found this gap in the literature, and that there's really a need for this type of work. And the reason why most of those 2000 papers were not included was because they were, while they included our search strategy, they were really around other topics like safe conception for serodiscordant couples, prevention of vertical transmission, and fertility desires. And that's not what we're getting at. Ours is really a quite niche topic around perceptions about how HIV and ART affects a woman's biological ability to conceive. And there's very little on this topic. And so ultimately, what we found is there's a scarcity of research on this. And what I'll present very quickly is just some of the papers we found that touch on the topic, but none of them really went into the kind of depth that we'll be doing in our second aim. So we found, in terms of perceptions about the relationship between HIV and fecundity, and keep in mind that this goes back to 2000, right? So some of these attitudes and knowledge will have changed. However, attitudes and knowledge do take a long time to change, and past generations might continue to communicate different types of information. So one study found that couples assumed HIV made them infertile, so any pregnancies were accidental. Another found the widespread belief that the vaginal ring for HIV prevention causes infertility. And we also found that providers reported being open to discussions about fertility, but in some of the same studies, patients wrote that they were dissuaded from having children, and so they didn't seek preconception counseling. In terms of perceptions about the relationship between ART and fecundity, it was predominantly positive. Couples noted that ART increased their desire for sex and thus pregnancy in some cases. In another study, women reported that they tried to improve their ART adherence to enhance their own fertility. And another study said that ART really restored hope and helped women feel optimistic about becoming pregnant. And then lastly, women reported that their providers advised them to get healthy or improve their CD4 count through ART before attempting pregnancy. Although some women felt that was a little bit intrusive, and they wanted to decide when they were going to attempt pregnancy without seeking their doctor's advice or permission. So fortunately, the recommendations for future interventions are aligning with our plans. Some studies reported that women require information on the impact of HIV on pregnancy outcomes. So specifically with an emphasis on the restoration of fertility after ART initiation. There are calls for capacity building, which I imagine will be a part of our future intervention. Capacity building to train providers on current information and data around HIV, ART, and fecundity. And there's a call to use qualitative data to develop culturally relevant interventions around reproductive health and HIV. So the next steps for this work, as I mentioned, there's a second aim. So really it's to assess the current understanding of how HIV and adherence to ART affects fecundity. So we'll do that by conducting 60 in-depth interviews with men and women living with HIV in Kiambu County, Kenya, right outside of Nairobi. And we'll also conduct 30 in-depth interviews with medical providers who care for people living with HIV. And that will help us understand, what are medical providers saying to people about, to their patients about this? Are they saying anything at all? Is it accurate? Do they require training? And this will then lead into the next step, which would be developing some type of probably communication module between patients and providers to raise awareness about this. So I just wanted to thank my mentors, Monica Gandhi and Kenneth Naguri, my research team, of course, the UCSF CFAR, and the NIH National Center for Advancing Translational Science. Thanks, everyone.
Great. Thank you so much, Erica. That was a great overview of your work. Let's open it up we have time for a question or two. I'm looking at the chat, and you can feel free just to come online and speak your question, or you can put it in the chat. While people are putting their thoughts together, right? With the next steps that you outlined, a lot of your work focuses in different parts of different countries in Africa, right? But you're focusing on Kenya for this particular part of the work?
Yeah,
Is that right?
that's mostly for a feasibility reason to, to conduct the interviews, and then to for the third phase when we do a survey and do objective biomarkers. We want to, Monica Gandhi's my primary mentor, and so we're working with Kenneth Naguri
Mhm.
and Kemre and Jomo Kenyatta University to recruit and to so we'll have a snapshot of one place in Kenya, but ideally future research could move on to other locations, but that will still give us a snapshot of what people think in Kenya, and where there's a lot of women of reproductive age who are getting HIV and who have HIV right now.
Great, great. I probably follow-up questions, but I'm going to not hog all the time. So Monica has her hand raised.
Yeah, that was a great overview. My question was that is there been any studies that looked at the old antiretrovirals and women's perceptions of those as maybe not helpful fertility, because you had to take multiple drugs and they did have multiple side effects, as compared to where we are now, which is dolutegravir-based regimens. And there was some hiccups with that when it first got rolled out from a Botswana cohort. But if there's a dolutegravir specific study where women say, yeah, this one is, I'm not worried.
Yeah, no, that's a great question. I think that's a key question, right? Because ART has changed so much in this. The systematic review was across almost 25 years, and ART has changed so much, and perceptions around HIV and ART have changed so much. So there's so little data that there was nothing comparing, different types of ART or saying names specifically. There weren't even any studies that focused on this topic. There would just be like one sentence or one finding within a larger study on reproductive attitudes or knowledge. But I think that's exactly what we will try to get at when we develop the in-depth interview guide and with patients and providers, is to understand perceptions about ART now, and potentially ask about if those perceptions have changed now that the technologies have changed.
Great. All right. I think we should move on to the next part of our agenda, our program for today. But if you have questions for Erica, please put them in the chat. And Erica, if you don't mind, monitor the chat later and see if there's some questions that emerge. Otherwise, I don't mind volunteering that Erica would love to hear from you if you email her or contact about her work, right? Is that safe to say? Because I already said it. Good. Great. All right. So Erica, we'll turn it back over to you to introduce our speaker.
Yeah. And I'm happy to introduce Dr. Jessica Haberer. She is a professor of medicine at the Harvard Medical School and the director of research innovation and mentorship at the Massachusetts General Hospital Center for Global Health. Her research is multidisciplinary, involving clinical epidemiology, behavioral science, mHealth, implementation science, data science, and ethics. She works primarily in the prevention and treatment of HIV and tuberculosis, and her current research is in Uganda, Kenya, and South Africa. Welcome, Dr. Haberer.
Great. Well, thank you guys so much for the invitation to be here today. And I see many familiar names and faces, and many of whom are involved in the work that I am presenting. So this is really on behalf of a much larger team. So I will go ahead and share my slides. Okay, are you able to see that?
Yes.
Excellent.
Looks good.
All right. Okay, great. So, and I apologize. I think when I initially sent out my title, I hadn't included all of it. So if it was a little cryptic, my apologies. But what I'm going to be talking about today is a new way of thinking about our understanding of HIV prevention needs that's specifically related to a type of data science called sentiment analysis, and thinking about how to use that in social media. So these are my disclosures. So what I'll cover is the way that I and my team think about like the current approaches to understanding HIV prevention needs, and where there are some gaps in that, and how we can think about this novel approach of using social media as a way to think about identifying people who may have HIV prevention needs that are going unmet, or to help people just calibrate and understand how their lives and their behaviors reflect concern for HIV. I'll give you some initial results that we've been able to learn through a study called SMART, or Social Media as a Risk Tool. Most of our work to date has been in the ethics of making sure that we do this work properly, knowing that there are some potential concerns. And I'll give you just a teaser as to what we've been able to find in terms of the actual assessment of HIV prevention needs, and then let you know where we're headed with this work. And please feel free to interrupt at any point or pop your questions in the chat, and we'll get to them as we go. Okay, so just to put us all on the same page, I think most people who are on this call know that we have many effective tools for HIV prevention today, whether that's testing, condoms, oral PrEP, injectable PrEP. In theory, I think we're having trouble getting it out there, but in theory, we have injectable PrEP. Counseling to help with any kind of sexual behaviors, substance use, mental health. There's U equals U. There are substance use treatments. There are all kinds of things we can do to help prevent HIV. But it really depends on people coming into our system, whether that's the mental health system, the healthcare system. But people have to present, and I think most of our tools to be able to understand how much of a risk is there for HIV, we have to have those people coming in the first place. And I think that's one of our major gaps. And several years ago, some colleagues and I developed this concept of prevention effective adherence. This is from an AIDS paper now almost 10 years ago, which seems crazy. But this concept is really just, as you see in the bottom part here, where when you're looking at HIV prevention, and this paper referred to PrEP specifically, but you could substitute any of the tools I just showed you for PrEP here. If people can know when they are in need of some kind of HIV prevention, like these arrows down here, then they can use the tools. And then when they don't have any kind of risk or potential need, they don't need to. And it just really helps people find the tools that they want, understand the different choices that are available, and really maximize their HIV prevention in whichever way makes sense for them. But again, they have to be able to know. So a lot of different approaches, I think these are probably going to be familiar to many of you, are risk assessments. So some kind of combination of behaviors, demographics, that sort of thing. And just of note, I did try to review the CDC risk assessment and got this warning, which I think is kind of speaking to our current geopolitical status. But in any case, in theory, there is a CDC risk assessment out there. But again, all of these tools require that people come in. And they're often also thinking about HIV prevention as a risk, which is a concept that I think many people are trying to get away from, because most of us don't walk around thinking about risks. We might be thinking about, what are our relationships, what are our needs, what are our priorities. And so are there other ways that we can think about this? Especially because many of these approaches help, but they have some limitations in terms of actually being able to know if somebody may be concerned about HIV. So one of these in particular that I've used quite a bit myself is the voice risk score. And there are different ways you can use the risk score, but this is the screening tool that we used in a study called MPIA, which I'll talk about in a minute. But this was how we screened people in for that study, looking again at some demographics, some relationship characteristics, use of alcohol. And this tool was very helpful in many ways in terms of identifying some potential needs for HIV prevention. And it was developed, as I'm sure many of you know, from voice, also using data for validation and cross-validation with HBTN 035 and FemPrep. And it had a reasonable performance. But in extrapolating out to other studies like the ECHO trial, the performance was not as good as I think people had hoped it would be. So that leads us to why we developed the study called SMART. So as Erica mentioned at the beginning, I've been moving into data science in the last several years and trying to think about what we can learn from data. And I came across some colleagues at CHI, actually, who've been talking about how to use natural language processing and understanding what people are saying to each other in social media or texting, and trying to learn more about behaviors in that way. So it's passive analysis of existing content that people are sharing with each other or posting, more broadly. And so just to be clear, if you're not familiar with sentiment analysis, it's a way of understanding the meaning of maybe words, maybe patterns of words, sometimes in a social network structure. So there are many ways that you can play around with this type of data. And several others have been looking at this approach for things like microloan repayment. This was the first way I heard about sentiment analysis. And it was a very interesting study done in, I think, Bangladesh initially, and where they looked at just text messages and the frequency of word counts and so forth, and the types of networks that people were engaged in. And it actually predicted loan repayment better than a standard background check, that kind of approach. I'm sure you've heard of people using Twitter analyses to try and track, viral transmission. It's also being used to predict sexual behavior, substance use behavior, but it's really in, I would say its infancy. I don't think the way to actually implement sentiment analysis has made it to the mainstream. So this seemed like a great area to explore. So as I mentioned in PIA, this is monitoring pre-exposure prophylaxis in young adult women. This was a trial that, again, many people on this call were participating in a few years ago in running this trial. So it was 2016 to 2020. And we were looking at prevention effective PrEP adherence in young women in the Thika and Kisumu areas of Kenya. We had lots of data really trying to understand what it was like to take PrEP. Did reminders help or not? And they didn't, but we learned a lot about how women take PrEP and how they don't take PrEP. And in this trial, we did a small, quick and dirty pilot, if you will, of this idea. So this was towards the very end of that study. And we approached 70 women who were in the Kisumu site of the trial. And we just asked them, what kinds of social media do you use? Do you use Instagram, Facebook, WhatsApp, texting, and social media can be, understood in a lot of different ways, but we asked about all those different platforms. And everybody used SMS, but it was actually pretty difficult to work with SMS because people don't always leave the messages on their phones. And then getting access to data that was within a telecom provider is much more difficult. But a lot of people use WhatsApp, and WhatsApp is actually quite easy to work with from a data perspective. So of the 70 women we spoke to, 56 said they use WhatsApp. So within those 56, 39 were very comfortable providing us with their data. 26% or 15 of those women didn't come back for the visit in which to give us the data. So we don't know if that means that they actually didn't want to give us their data or they just couldn't come back. But only 2 people said straight out, we don't want to do this. We don't feel comfortable with this. But 79% of them said that they were very comfortable. If we were able to do this in the future, and 100% of them would provide the data if they thought it was helpful. So this to us was a green light. Okay, so we recognize that, working with people's data has a lot of potential ethical concerns, legal concerns, around privacy and that sort of thing. But most of the women here felt like, yes, this is something I would be willing to do and actually very interested in doing if it would help me understand my needs for HIV prevention. So on that data, we did a preliminary sentiment analysis. And just to break this figure down here, these topics, so you can generate a variety of approaches to understanding how these words are clustered and how that meaning could that be correlated with other like risk factors or any kind of outcome. And so in this preliminary analysis, our team actually translated all of the text from Swahili and Luo and combination of those 2 languages and English and teenager or young person because of the way people speak. It's not necessarily coming out of a grammar book. And then there are emojis and, there are lots of things that people use to communicate. So we simplified it as much as we could through direct translation. So something that was very labor intensive, but gave us a proof of concept so that we could really understand this as a team. And we broke that down into 5 clusters of what we call, topics. So words that seem to hang together in a way. And this bottom one here, the topic number 5, had a religious theme, and we compared that to the voice risk score, and we saw, quite a significant relationship. We saw more minor relationships, still statistically significant, but perhaps less strong and less clear in terms of what did topic 2 mean. Oops, I didn't mean to do that. What did topic 2 mean? What did topic 3 mean? But again, we were just looking with this preliminary data for a green light to move forward with this analytic approach. So as we were thinking about how to formulate
Jessica, can I ask you a question? Can you go back for a minute?
Of course.
I know you offered me. So just so I'm interpreting this right, so that topic 5, that's lower risk, yes? Is associated.
Yes, exactly. Yeah. So there was a relationship there that people who were texting, sending WhatsApps about religion had a lower voice risk score.
And I had lots of other questions about the other topics, but that's probably, we don't have time to get into that because they're.
Yeah, no, I keep checking my watch to make sure, because I could talk about this stuff forever, because I think it's really interesting. And hope you do too. All right. So as we were.
Sorry, I just had a quick question, if you don't mind.
Yeah, sure.
If you go back to the previous slide. So you mentioned how you ran sentiment analysis and then used that to get 5 clusters out of the SMS data that you have. How did you elucidate the topics of the clusters?
So those came out of the data themselves. So you can and I'll get into this a little bit with some of our actual, like our current study data. But you can pre-specify how many topics that you want from the data, and then the data, it's sort of like trajectory modeling, if you're familiar with trying to identify that. You can allow the data to do it based on the strength of the association. You can pre-specify it. If you only want 5, the data will show you 5. So there are many different ways you can go about it. And to be honest, I'm not the one who's doing the coding, so I couldn't tell you the specifics of how this comes about. But there are, I would say, more behavioral approaches to understand if the topics make sense, as well as statistical approaches to understand how well the data hang together.
Gotcha. Thanks. It's very cool. I was just wondering if these topics were based on like the frequency of the words that were being used, or the differential frequency, like these words make this topic stand out from the 4 others. That was kind of like my main question.
So it's So it's primarily on how often they are associated together. And in this analysis, that's all we did. And the one I'll talk about a little bit later, we're also looking at the person with whom that information is shared, because there may be additional information about that type of relationship that influences what that association means. So there are many different factors to play around with here, but with this initial kind of pre-pilot, we just basically looked at how often the words were associated with each other.
Got it. Very interesting. Thank you.
Sure. Allison?
And here you're just asking them to gain access to all their WhatsApp messages.
Yes.
Okay.
Yeah. So in the pre-pilot, we asked them for 3 months worth of their WhatsApp messages. And I'll go through this a little bit more in detail when I talk about the SMART trial as to how we're actually asking people for their information. Okay. I will move on, but thank you for the questions. So obviously, as I was saying, there are some potential concerns with this. So as much as we think there's a lot of potential here to bring people into a healthcare system by looking at their day-to-day lives in a very passive way that, again, doesn't require people to think about risk. It doesn't require people to fill out a form or think about what their behavior is, and then you bring in all potential sources of bias and so forth. This would be more or less like in many ways, like a Fitbit or, like an Apple Watch telling you what you're doing with your day-to-day activity. This is more of an analysis of what your behaviors and relationships may be saying about your health, and in this case, HIV prevention needs. So we've been taking this very seriously and want to make sure that the ethical and legal issues are well accounted for before getting further into this type of research. So we obviously were thinking about privacy and confidentiality, but we've been working with bioethicists who also highlighted how important bystander impact is. meaning that we could ask people to give us their data, but what about those other people, who are involved in those conversations? This would be a little less of an issue if we were looking purely at something like Instagram, where you are posting and not exchanging information like you are with WhatsApp. But even with that, there are comments. And so, these issues really apply to any platform. But in speaking with our bioethicists, which I really enjoyed, it's been a great kind of dimension to a lot of the more clinical research that I've been doing over the years. But they frame this in terms of, the concept of equipoise. Like, is there a question here that warrants further investigation and balance of like, what are the risks and what are the benefits? And the way we sort of crystallized the point is that HIV prevention needs are not being met through existing approaches. They work sort of, not completely. So there is an ethical rationale to move forward and to consider what are the inherent risks and what are the benefits that people may get from doing this sort of work. And also because this work is in Kenya and every country is different, sometimes even finer segments of regionals, like in the US states and so forth, have different rules about what can be done with this type of data. But everything I'm describing here is in compliance with the Kenya Data Protection Act of 2019. So that brings us to the study that I'm presenting to you today, again, with many of my team members on the call. So we have three aims to this study, two of which one is completed, one is well underway, and then the third one we're just getting started on. But the first one was to explore these ethical issues in depth through qualitative interviews where we focused on privacy and confidentiality. We then went through the kind of traditional four. If you do any ethics work, you'll see that as kind of like the canon in terms of ethics in looking at autonomy, beneficence, non-malfeasance, and justice, but also recognizing that there are many other factors, particularly in the global health context, where we need to think about power, perspective, who's asking for this information, who's working with this data, and then colonialism on top of all of that. So we looked at these issues through qualitative interviews with young women. So this is our target audience of women who, many of whom, I would say probably most, have access to smartphones. Not all, but it's pretty common. And this is a demographic for which obviously there's a lot of work ongoing around HIV prevention. So we were working with 4 clinics in the Kisumu area that reach a variety of women within this demographic. And then we asked them, hypothetically, because this is preparatory work for actual data collection, would you be willing to do this? We had a green light from our pre-pilot. And we felt, again, it was comfortable, we felt comfortable enough to move forward, but we wanted to make sure that wasn't just, who we happened to ask. Maybe there was some social desirability from people participating in our trial. And so we asked women as we were screening them, I think somebody might need to go on mute. Okay. Would you be willing to do this? So trying to get people for whom this is something that is appealing, and they may have their own kind of bent to their responses. But we also wanted to make sure we got those opinions from people who were kind of sketched out by this and didn't really want to participate. So we had half and half, and then we had a couple of focus groups with Kenyan bioethicists to make sure that we were understanding the ethics specific to the context. So I'm going to go through a number of results here very quickly, just because there's a lot to get through. But this is really rich data, and I'll show you in a couple of slides some of the analyses that our team has been presenting on this work in much more detail. But our recommendations that came out of these interviews, I'm going to summarize those first. And I will say that we asked specific questions about ethics, but the participants were really engaged and wanted to just tell us what to do. So even though we were focusing mostly on ethics, they wanted to tell us how to build the app and how they would use it and how it could, really integrate or replace certain functions within the healthcare system. So we were not having to pull teeth here. Like, people were really interested in giving us their opinions. They even named our app. They wanted to call it Jujua Smart. So getting to know how to be smart in Swahili. I'm sure others could translate that better than I did, but something like that. And so, some of them talked about what is the type of functionality that this approach, for the app should have. And we ended up, as I'll say in a few minutes, not including messages from bystanders because of the inability to get their consent. But actually, many people suggested we should include them. They also suggested a chat feature to help people understand what this kind of app would do. They suggested a lot of education around HIV prevention options, safe relationships, other health concerns like STI screening and testing, and even cancer, and just getting advice on safe sex practices. So I think there's a real hunger for lots of information beyond what we had initially intended in terms of assessment for HIV prevention needs. People certainly did want to have security if this was an app that could be downloaded onto your phone so that you could run it, just with your data on your phone, wanting to have a password to make sure that was protected, and that everything was handled anonymously. We wanted to make sure it's free, data efficient, available if there's spotty internet. And they gave us lots of advice on, what it should look like, how the information should be shared, making sure that there is feedback. So if there is a suggestion of high risk or high prevention needs, what to do with that information, and including even support to peer groups. So some of the information we received was also about behavior change that could happen through getting this kind of information. And as I said, I'm going through this relatively quickly, so I'm not giving you a lot of quotes, but I did want to share this one from a 20-year-old woman who said, "Maybe I will know how to control myself if I know," so I have to move my screen a little bit, "if I know that I am not at too much risk, so I don't get infected, because I would know where I am." So it's sort of that, again, that Apple Watch or Fitbit kind of understanding of behavior that many women were pretty excited about. And that could help them with decision making, knowing that they need to go look for services. We could even include where those services are on the app and just generally increase awareness. But that was balanced by some potentially unfavorable or unintended impact, that it could actually encourage discontinuation if someone was found to be at low risk or low prevention needs. Maybe they would stop doing things that were actually beneficial for them that were not somehow taken into account, particularly if there was some kind of inaccuracy in the algorithm that this may not work. And so somebody could be in need of a lot of HIV prevention services and not assessed accurately. So we did, very explicitly ask people what are their concerns. And, as you can imagine, many did talk about privacy and confidentiality, particularly around the researchers understanding this data, developing the algorithms, but also, in the future, if this is something that we develop. There were potential ethical risks with either deliberately or inadvertently, including those messages from others. And I think we are, as I said, we're going forward with not including that information, but there was, encouragement to consider the impact of that information. We're also not looking at deleted messages, but people did ask about that quite a bit. There was some unease or embarrassment with some of the messages, which, talk about very sensitive subjects, and people were worried about data leaks or hacking. And our bioethicist colleagues in particular were concerned about how do you actually get real consent for this, knowing that people feel very comfortable or very differently in their comfort levels with sharing information. Some people are very hesitant, and other people are very, very open. So making sure that the information to make that decision is available. So they also gave us their mitigation strategies. So having strict data security, using codes instead of names, deleting photos, using alternate phone numbers, many things that I imagine are familiar to most of you in terms of protecting participant identity. That some people suggested evaluating possibilities of getting consent, and for these bystanders or even the deleted messages. But again, for now, we're not going down that path. The issue about consent is something that they suggested to address through an iterative process of trying this out in different ways with different groups. And then exploring the feasibility of filtering out certain information, and using maybe public sources of data instead of having to go to individuals. Although what we're really hoping to do is tailor the use of this algorithm to a specific person. But it was an interesting idea in terms of development. And then having ethical bodies define the guidelines on the legal threshold for what would be allowed. And there was some concern about, if we found criminal activity or something that needed to be reported, how would we handle that? And fortunately, in this type of analysis, we really aren't looking at specific words and that meaning. It tends to be more about words as tokens in a way, in terms of like the data analytics. So that I think is less relevant than the participants were concerned about. But again, it's important to know like what could be perceived as a risk. So there are also a lot of mental health implications that we had not initially anticipated in collecting this data. And they fell kind of into two buckets. So one is if people were found to have low HIV prevention needs, so not a lot of HIV risk, that information would be perceived very well, and there would be increased confidence and self-esteem, could be, very proactive in terms of being able to talk about what they're doing with their healthcare providers, and people feeling much more comfortable about their sexual health, and particularly if they were able to use the app with a partner. But on the flip side, if the HIV prevention needs were found to be high, people were very concerned that the individual would be isolated socially. There was a lot of concern around anxiety, awkwardness. You can see everything here on the screen, including even suicidality. And particularly if this data became available in a leak or in some other way, and a lot of concern about judgment. So I think these mental health implications are really important for us to consider, and something that I think could be overlooked if you're just thinking about a risk tool, like some of the things we talked about earlier in a clinical setting, because this will be out there if it moves forward in the public without that, I guess, safety in a way of a clinical environment where services are automatically or at least feasibly linked. So just looking at time, let me just pause and see if there's like one or two questions about this before we move into the actual data. And I know I covered a lot of the different perspectives and ethical issues, but does anyone have any questions to clarify about that? Peter.
Yeah, hey Jessica, really interesting. I'm wondering, do people use WhatsApp exclusively? Are there other messaging apps that people might use? And if people know that sensitive conversations may be reviewed by researchers in WhatsApp, might they use a different messaging app for conversations that might impact risk?
Yeah, it's a good question. So WhatsApp is by far the most common way that people communicate for this type, these types of conversations. I mean, still SMS is definitely out there. And who knows what will come around next week. This field changes very quickly. And some people did say that if they knew this data was going to be accessed, they would delete certain things or maybe talk to somebody in another way. But our goal in doing such a deep dive into understanding what people want, how they would use this, is to make it something that people want for themselves. So if they delete messages, they're only like reducing their ability to understand their HIV prevention needs, or anything else that this approach could be adapted to. So I think by my hope is that by paying attention to all of these issues, we could design an app that shows that this is really for an individual, for their purposes, how they want to use it, and that would reduce the intentional bias, that could come in from somebody selecting or changing their behavior to make the data look better. Okay, let me keep going, and then we'll have a little bit of time at the end. So this was all of our preparatory work, and we took this into account as we actually went out to collect this information. So make sure we were, explaining everything very clearly to our participants in terms of deleting photos and not using the bystander messages and talking about all these potential issues so that we could be comfortable at this stage where we're just trying to see if this algorithm works. Like, we're not actually developing that app. That's a couple of steps further down the road. But we wanted to do this right. So we felt comfortable with our approach, and we went out and collected a lot of data. So this is representing 6 months of messages from each of 400 women. So it's a lot of data. As I mentioned, we've been working with 4 different clinics in the Kisumu area. And we collected, in addition to the WhatsApp information over that 6-month, the most recent 6-month period, we looked at their social demographics, and we got the information that would be used in a voice risk score. We also looked at the WAN risk score. We did get up to 20 contacts. I know some of you on the call do social network analysis, so it wasn't super, super intense. But we did want to know who did they communicate with most of the time, and we did not ask for names. We were able to label the phone numbers with something like friend, romantic partner, family member, just to have a sense as to what those conversations may be related to in terms of that relationship, and then having HIV testing for all the participants. So how did we do this? And we spent a lot of time working with the legal advisors to make sure that what we were doing was okay for Kenyan law, as well as for the US, because this is an NIH-funded study. So we were able to download the data securely without potential for it to be leaked. We used Python code to strip out the bystander messages and any images. And then we went through a process of de-identifying and then coding the phone numbers for security. And then this 4th bullet point is only one bullet point, but it's a huge question as to how do you deal with multilingual information. And again, like different approaches to the linguistics themselves, knowing that people communicate very differently than they do in grammar books. But suffice it to say, for sake of time, we ended up using a multiple layer approach to translation from Swahili to English or Luo to English. And it's not perfect, but it is something that can be automated. And I think this is something that we're going to have to pursue over time. And fortunately, more and more innovation is coming in African languages. So it's not just, English, Spanish, French, but there's a lot more going on across the African continent to promote use and the ability to analyze data in many, many languages. And so then we dove into the chat content analysis with simple textual counts, topic modeling, various types of analysis around the sentiment, valence, like arousal. These are common terms within sentiment analysis. And then we used a downloaded LLM, or large language model, in order to make sure that the data that we collected and analyzed was not being shared back to the internet and technically available to other people. So that actually slowed down a lot of our analysis, but it made sure that it was protected for our participants. So what I'll be able to share with you here is that we have 400 participants. 89% were negative for HIV, 2 were positive, and 41 declined testing. As by design, they were all young women, so 22 years old on average. And we got about 10,000 files per person, or 10,000 files total, 25 chats per person. And just to give you a sense of how people communicate, most messages are very short, a few words, but there may be up to 50 messages per chat. So each of these distributions here is showing words per message, number of messages per chat, and then the temporal length of the communication. So most lasted, less than 3 months. And this is what our topics look like. So we have not done a full analysis yet, but I was very reassured in a way to see that these kinds of concepts are coming across that hang together in a way. Some of them are not quite as obvious as these, but they make sense in a way. And understanding how this relates to English and Swahili and Luo and again those linguistic nuances, it's really quite complex. But we are seeing things that make sense. And sorry, this is a little bit fuzzy, but this is how you go into some of the analysis to determine which topics you're going to create and how many you want. Right now we're looking at 10, which you can see in all the different circles on the left. On the right, you're getting into like how relevant the topics are within that cluster. So as I mentioned before, we are exploring a number of different ways of doing this. So I wish I could tell you, does any of this correlate with the voice risk score? Does it correlate with HIV, prevalence? We don't know yet. So we are in the midst of this. This is definitely research in progress, but we are in the nearing the completion of the code that's necessary to analyze all of this data. So we will be looking at both voice and wand. And we recognize that those are imperfect comparisons. Ultimately, we would like to be able to look at HIV incidence, but we need a bit more proof of concept here before moving to that kind of scale. And then finally, in our third aim for the study, we are looking at practical factors that could influence how this would be used in the future. We actually got a lot of that already, as you can tell from what I've shared with you, but we're just starting next week some focus groups with young women and healthcare providers to get a little bit of an implementation science sneak peek as to, if this really works, how would we want to roll it out, either within a clinical setting or in the community. So we're working on all of this in an app format, refining our translation approach, exploring other LLMs like maybe DeepSeek, or who knows, again, what's going to be out next week would be better. A lot of people have suggested we analyze emojis, which we haven't been doing. So there are many things to explore. And if all of this ends up working, I would love to see this move forward in an HIV incidence study. So to conclude, sentiment analysis, I think, is a really interesting avenue to explore so that we can reach people who are not coming into the healthcare system. And I think that's the main goal with all of this. So we don't have to focus on risk. We don't have to ask people, what, do they like or very much like, or do they sometimes, or, all of those Likert scales and things like that can be really difficult and to report and to understand. We can do all this, I think, within an appropriate ethical and legal context. And I think there are many applications to this approach that go beyond HIV prevention, thinking about screening for mental health or any other kinds of behaviors that we could glean from this type of information. But there are many key considerations. I've mentioned multiple times, like how challenging this can be to work in multiple languages and different types of communication, which evolves constantly. We really have to be careful with the ethical concerns and mental health impact. Again, that wasn't something that I personally was, I think, attuned to enough as we were planning this, and was really grateful to our participants for raising that. And knowing how important linkage to services will be if we are going to do this out in the community. And then, if this is something that we could roll out, into the Wild West in a way, that's a whole nother level of understanding the security that would be needed outside of the controlled research context. So as I mentioned at the beginning, this is a huge team effort, and I just want to highlight our team who've been presenting these results just last week at the University of Nairobi STD, HIV, Sexual Reproductive Health Collaborative Research Group Annual Review. Perez Ochwal presented on some of the influences, as I described. Marian Hewa presented on the recommendations for our tool. And then next week, there will be the KEMRI Annual Scientific Health Conference, where Lydia Adima is going to be presenting on the mental health implications, and Alfred Odiara is going to be talking more about the ethical concerns and some of the mitigation strategies, as I very briefly shared with you. So I want to acknowledge, again, the team here, and I'm just realizing now I neglected to include our North Carolina State colleagues who've done all of the coding that I've described. So I will have to correct that for when we send out these slides. They've been incredible partners in the data analytics, and really grateful to them, as well as everyone you see here, and of course the NIH and our study participants. So thank you very much, and I would love to take any questions.
Fantastic. Jessica, thank you so much. I know Lawrence had a question in the chat. Do you want to come online and ask your question, Lawrence, or would you like me to like us just to respond from the chat? Okay, maybe Lawrence is not. Okay, so what Lawrence was asking was, can we consider analyzing use of emoji to assess the risk as well as addition to SMS? Most young women like using emoji. In case your work wasn't complicated enough, this is fascinating. What do
No,
you
so yeah, we initially, and Lawrence, we can talk about this more next week. But the emojis, we originally were just going to like not deal with anything that was a GIF, an emoji, a picture, because it's just complicated. But there are signatures with each emoji. So I think moving forward, just knowing how important that is in communication, especially for getting a sentiment, to attach to some text, I think that would definitely be something to do going forward. I can just look in the chat too. So Judy, cool stuff, thanks. Parallels with the biomarker stuff we were thinking about, the benefits and risk of biofeedback. Okay, she had to run, but
think Erica
thanks
has one though.
to-
Erica, do you want to?
Erica.
Yeah,
Okay.
no, I'm really interesting. Thank you, Dr. Haberer. I was just I love seeing the word clouds, but I was just wondering what are your next steps for data analysis? Because I'm in more of the traditional like exploratory factor analysis, but that's with traditional data. So I'm just wondering how you're planning to come up with themes and words that hang together. What are your plans?
Yeah, so the next step is that correlation. So if you remember back to the pre-pilot that we did, where we had the 5 topics that were correlated to the voice risk score. So that's the next step. So we've done this initial analysis on about 250 of the 400 participants' data. So once we finish running it, and again, because we had to download the LLMs, it actually takes a long time to go through the, however many messages somebody has and all of the text within it. So it's taking us a few weeks to actually process that. Interestingly, with DeepSeek, you can do it like almost instantaneously. So I think there's so much technology that's progressing that'll make this actually feasible to do in a much more real-time sort of approach down the road. But we're going to look for that initial correlation to see if those relationships, like that religious cluster, if there are if we find that in this much more robust data set, then that would tell us that there is something to do here, and we can refine that for a larger HIV incidence study.
Great. And so we're out of time, but we have maybe time for lightning rounds. Both Monica and Peter had their hands raised with questions. So if we can do them super fast, we can get through those maybe before people have to leave.
Well, I think Judy Hahn's going to follow up on that is the biofeedback. So she uses this alcohol biomarker data to biofeedback. So you have been doing a lot of adherence around the concept of biofeedback and using objective data. I'm curious about that.
Oh, so like introducing objective data into something like this?
Yes.
Yeah, I mean, it's a great idea. I hadn't actually thought that far ahead. But yeah, I mean, I think this is proof of concept, and as I've been presenting it in various stages. But if we can get this to work with words to some extent, could we add in other sources of information? I think that would be great. It's a really interesting idea.
Thank you. It was really interesting.
Thanks. Peter?
Peter, and then
it was a bigger picture question, but it may be not enough time. But just both with the biomarkers and with these data, I get that the social desirability bias of not wanting to, perhaps give a truthful answer about a sensitive subject to a provider. But when you're doing it just with your own data, you have the feedback for yourself. I still wonder whether there might be some avoidance of getting those messages, and I wondered what in the behavioral health world, whether that phenomenon exists even when you're not presenting it to a provider and you're just getting personal feedback.
I'm sure that's there, and I'm not a psychologist, but I fortunately work with a lot of them who can help us think through a lot of these issues. And there's no tool that's going to work for everybody. Like if people, maybe even just by knowing that they're going to change their messages, for an app like this, maybe that itself could be like a clue that maybe I do need to go talk to somebody. So maybe, that's one benefit, even if people can't actually use the tool as designed. So I think these are things that we'll have to explore if this all works, so hopefully maybe I can come back in a year and tell you what everything looks like after we've crunched all the numbers. But so far we've learned a ton. I think it's a really interesting area, and we are seeing signals that hopefully we can continue to move forward.
Sounds good.
All right. I want to thank both Erica and Jessica for sharing your work with us. This was a great session, and we really appreciate it. And thank you for your generosity of your time. All right. Thank you all for attending. And I'm going to go look at my WhatsApp messages and see what they might tell me. Yeah. Okay. All right.
Thank you.
Okay, thanks
everyone.
everyone.
Thanks,
Great.
everyone.
Bye-bye.
Bye.